This is Kiruthiha Vimalakanthan. So she is a PhD candidate in clinical psychology at University of Waterloo. So she's driven by her passion to improve access to mental health supports in diverse communities. She's consulted on a various number of projects at SAC, and her primary role at SAC has been the development and supervision of SAC's CARES initiative, which employs a task-shifting, anybody that was paying attention to Vikram Patel earlier, a task-shifting model to provide mental health support for caregivers of children with autism. So I'll let Kira take it from there.
Thank you. So thank you everyone for deciding to attend this talk today. I think all day we've been hearing themes about the value of empowering a community to care for one another and the need for feasible programs to equip that community with the knowledge, the skills, and the resources that are needed. And at the same time, to make sure our efforts are based in evidence and of high quality. And today I'm going to be taking a little bit of time to talk about a program that I think marries that evidence with practice, or at least starting to in a really nice way. So what I'm hoping to cover in the next 30 minutes or so is to outline the development, the structure, and the initial impact of what we call the CARES initiative. And then also touch on how low-resource initiatives such as these have the potential to empower a community to care for them. So I'd like to start by talking actually to the second point that I mentioned, which is, in the spirit of this conference, the problem of access. As a therapist, I view one overarching goal in my work to be making myself obsolete. And I realize that to some people that might sound really radical. Obviously, there are individuals who might need support throughout their lives, and I'm certainly not suggesting people don't come to therapy, but for a lot of individuals, treatment moves towards helping clients help themselves. So equipping them with the different psychological tools that are needed and empowering them to take action to find their own solutions. But in reality, mental health services are among the most underfunded in our healthcare system. No surprise to anyone here, and most Canadians' needs largely go unmet, despite the sort of epidemic levels of mental health concerns that we have. And I think part of the problem, as we've been hearing all day, is access to professionals such as myself. So we're expensive, and wait times can be really long, and there just might not be enough of us. So given that this access is difficult, the question for me became, how do I make it easier to bypass me altogether? And last September, the CBJ, Canadian Mental Health Association, actually released a report identifying the 5 key areas of development to ending healthcare disparity in Canada, highlighting the importance of equitable access for all. And of course, maybe first on that list would be the logical next step of publicly funding evidence-based therapies. But I think the one that is especially relevant and valuable to the topic at hand is this one, number 3. So investment in promotion, prevention, and early intervention. So achieving good health requires that we invest in mental health promotion and mental illness prevention. This includes interventions that foster a healthy and resilient mood, create supportive environments, and allow individuals to develop their personal skills. Interventions such as parenting programs, anti-bullying programs, and workplace mental health initiatives. Given that social conditions and inequity play pivotal roles in shaping population mental health, we recommend that social spending should increase by at least 2%. And I think this goal really nicely dovetails with the ideals that gave rise to SAC-CARES. In case you're wondering what CARES stands for, it involves counseling, assistance, reinforcement, and empowerment services. In a nutshell, it's a group-based psychosocial intervention designed to target the social, emotional, and psychological challenges that can arise among caregivers of children with ASD. And this intervention takes the form of a peer-facilitated 6-week group counseling program with about 1-hour sessions taking place once a week. And I'd like to spend a little bit of time highlighting 2 elements of this program that I think are really important. One is the aspect of being peer-led, and the other is the group format of this program. So Rohan in his introduction mentioned task shifting. So what is task shifting? Effectively, it is shifting service provision from professionals to health workers with fewer qualifications, or as we did in this case, creating a new workforce with specific training for a particular task. So in this case, the caregiver support program. And task-shifting approaches to mental health care are actually emerging as an effective and feasible solution to the lack of both human and financial resources for service provision. So a relatively recent review by Kakma and colleagues, for example, suggests that with brief training and also appropriate supervision by mental health specialists, non-specialist health professionals, lay workers, caregivers, and even affected individuals are able to support individuals with mental health concerns and reduce caregiver burden. And up till now, much of this research has mainly been conducted in low and middle income countries, but I would argue that this is applicable to the problems that we face here right in Ontario as well. And the other aspect of this task-shifting approach that I'd like to highlight is the idea of peer volunteers with shared experiences. So volunteers from the same community with relatable experiences as the target group have been found to be effective in delivering mental health interventions. And I think this element of the program also allows us to address barriers that prevent treatment seeking of mental health services in our at least initial target population of South Asians and other visible minority groups who have reported issues like language barriers and cultural incompatibility with healthcare providers as barriers to accessing. So who are our peer facilitators? The way we select them are based on their experience working with vulnerable populations and or their shared experiences of having been a caregiver for individuals with ASD. Having a professional background or experiences in mental health service provision were considered an asset, but not necessarily a requirement for selection. We also make sure that these volunteers have adequate supervision, so appropriate supervision by mental health specialists. And so currently, the people that we have supervising are a physician, Dr. Shivajan Sivakalan, who we will hear from later today, and a doctoral candidate in clinical psychology at IUP. So we also provide program-specific training. And this training includes on-site orientation, a seminar to familiarize facilitators with the program, its procedures, and the intervention guide. However, in keeping with culturally responsive practices, volunteers are also trained and encouraged to engage the groups that they serve through the use of shared cultural knowledge and frames of reference in order to make their learning more effective and relevant. So why support caregivers? This is probably a pretty obvious answer. Caregivers of children with ASD report elevated stress and social isolation consistently in the literature. And it comes as no surprise that parental mental health difficulties can act as a risk factor that compromises the entire family unit's well-being. And it can also have significant consequences for the developmental trajectory of the child. However, existing approaches don't systematically address parental functioning and instead tend to focus on parent training, for example, for behavioral management or methods to facilitate joint attention. And so taken together, this research suggests a need for interventions that directly address the problem of parental mental health. And so our program's aims are twofold. The first aim of this program is to provide parents with a forum to share their experiences as caregivers of individuals with ASD and develop a sense of shared identity. And the second aim of this program is to provide parents with the knowledge and the skills to support their own mental health, again, in a culturally responsive manner. So in terms of what each session looks like, I'm going to start to get into the content that we actually cover. But when parents come in, each session involves a progress check to see how they're doing, opening mindfulness exercises and closing relaxation exercises to actually model some of the content that we teach on a week-to-week basis. And then a combination of direct education about psychological topics, discussion, interactive activities such as role plays and letter writing, and skills practice to really maximize engagement. So the first big component of the CARES program, content-wise, covers stress and stress management. And again, this is directly addressing that need or that gap where parents are expressing that they have really high levels of stress. And as I mentioned, we have those experiential components that are modeled throughout. But a large part of this starts with helping caregivers explore and identify their own experience of stress and gain an understanding of the different ways in which stress can manifest. So for a lot of these parents, they might not necessarily recognize certain symptoms as stress, as it isn't always necessarily a psychological experience. Sometimes it can be physical or even behavioral. And also important is the takeaway that stress is a shared human experience. You'll see throughout this program the importance of the element of really bringing out the common humanity of the experiences that these parents go through. We also spend some time specifically discussing the stress that might be brought on by a child's ASD diagnosis on the family unit. Going through, for example, the varying reactions to this, especially those typical to the cultures that we serve. We also encourage parents to experiment with implementation of strategies for stress management. So what's already working for them in their lives and really sort of encouraging them to actually make time to do those things, but also to experiment with sort of novel ways of managing stress that they might not have encountered before. And finally, we also make it a goal to help parents identify the difference between stress and burnout in order to help them gauge when they might need to seek professional help. And an important element of this is actually having destigmatizing conversations about treatment seeking for mental health. So discussing cultural barriers, and also perhaps the common view in this particular population that all resources should be dedicated solely to the child. The next big component of our program involves healthy thinking and rewriting our stories. And for those who are not familiar with these sort of euphemisms, this comes from a very cognitive behavioral framework. And the idea is that we teach parents how thoughts, behaviors, and feelings affect each other. Even just learning about, what is a thought versus what is a feeling and what is a behavior. And showing the links, how these three different components can actually sort of bounce off of each other and spiral. It's as basic as trying to notice how we talk to ourselves. The idea that we have a way of talking to ourselves and that can be helpful or unhelpful. And then also equipping parents with the skills to reframe those unhelpful thoughts. Or even understand, that there are certain ways in which our brain works to make our functioning easy, but at the same time can act as sort of traps. So this idea of cognitive distortions or thinking traps in the way that our brain works. Helping parents identify these concepts equips them with the ability to better actually challenge those unhelpful thoughts. We also help parents reframe by refocusing on strengths and resources. So some of the research that I personally do has a lot of grounding in compassion-focused therapy and theories. And so We've seen a lot of really positive responses to education about what self-compassion is and looks like, and doing activities such as letter writing or gratitude. And finally, we also spend a good chunk of this program discussing problem solving. So parents learn about the idea that there are different thinking styles. So for example, an emotional thinking style as opposed to a logical thinking style, positive thinking style versus negative thinking styles. And the idea that while there may be utility in an integration of those thinking styles, it can be really unhelpful to spend most of our time solely thinking from one certain perspective. We also use case studies to do group-based problem-solving activities. And this is actually one of my favorite elements of this program because it's really where these parents are able to come out of their shells and be able to distance themselves a little bit from problems that they can relate to, but at the same time, they're not necessarily being forced to talk about it if they're not comfortable. And so I found that this case study method, just anecdotally, has been really helpful to foster discussion in a very sort of safe context. And then, of course, there's also skills practice targeted towards assertive communication, as well as more specific topics such as conflict resolution in relationships. So I'd like to spend a little bit of time talking about the data that we've actually collected to date. We've run 2 iterations of the program so far and have just started our 3rd. Our sample size is limited, but we are hoping to grow this sample. Our current sample is about 63 people, 20 fathers, 43 mothers. The average parent that we see is 43 years old, has 2 children, and has a child with autism at an average age of 11. However, you can see also that the range that we serve is quite wide. So parental age ranges from anywhere from 23 to 63, total number of children ranging anywhere from 1 to 4, and the age of the child with autism ranging anywhere from 3 to 25. Now I'm aware that this is a busy slide, but I will walk you through it, and it's the research stuff, so I'm really excited. So we make sure to administer pre and post instruments looking at a variety of parental and family-related outcomes. So we focus mostly on parental indicators of negative emotional states, of stress and of family distress as a whole, as well as their quality of life, enjoyment, and satisfaction. Those measures are administered prior to the start of the intervention at week 1, and then post-intervention as well after week 6. And not much changes there other than a demographics questionnaire at the beginning and a feedback questionnaire at the end, with both sort of quantitative and qualitative ratings. Each session we also administer brief rating scales. The outcome rating scale starts the session, and it's a very brief scale measuring areas of life functioning, so individually, interpersonally, socially, and overall, how are parents doing? And then the session rating scale is a 4-item scale measuring key dimensions of therapeutic relationships. So how was my work with my facilitator today? Did we cover the goals and topics that I expected to cover? Is this approach or method working for me? And overall, how did I think the session went? And the nice thing about these session-by-session measures is not only are they brief, again, this seems like a lot, but at the same time, we're trying not to burden caregivers as they're coming in for services. But with the ORS and SRS, they're brief and allow clinicians to receive immediate feedback. So they're really easy to eyeball because they're visual analog scales, which basically means parents are drawing a line across a spectrum. So on to a little bit of the results. So some of the results will actually be covered tomorrow by Dr. Weiss and at his talk. But I'd like to show you the SRS ratings. These are the mean SRS ratings across sessions. And as a measure of the sort of client-facilitator relationship, SRS Report suggests that clients are liking the work that they do with our facilitators. This is sort of where you'd expect ratings to be for this particular measure. And although this is not necessarily a direct measurement of the program's effectiveness or fidelity, I think it's a good sign that our ratings are consistently positive, and it speaks to, on a very basic level, the effectiveness of our facilitators and the program content as we would expect. And I'm going to skip this scary table. We can go back to it for any research or data nerds in the room. But ultimately, what we're seeing with the measures that we've administered are findings that suggest decreases in depressive/anxious symptoms and stress over the course of the 6 weeks, decreases in parental stress, and decreases in caregiver ratings of their family's distress as a whole. And then we're also seeing increases in their reported quality of life. Now keep in mind there are a lot of limitations here. So first, our very small sample size. The fact that some of these effects are smaller in size, but then a little bit more robust with some of the negative symptoms. And ultimately, these are also self-report measures, so parents reporting, and it would be really nice to be able to build in future iterations of this program ways to collect that data to corroborate that data. And then from a qualitative point of view, what we've seen from parents in terms of what else they actually gain is, first, an understanding that they are not alone in their difficulties. And I really don't think we can underemphasize how important that this aspect of this program is. And also the foundational knowledge and skills required to identify and manage the experience of stress, as well as preventative skills that foster more adaptive cognitive styles and promote a positive self-concept. And ultimately, I think one of the most valuable elements is the sense of empowerment that they can gain as individuals and parents who can support both their own mental health as well as their family units. And actually, it's not even just themselves or their own family units. In the context of this program, we've seen more experienced parents reassure or share strategies with newer parents. And this is really nice because it not only supports newer parents, but presents opportunities for experienced parents to feel a sense of mastery in their parenting. So takeaways. So first, I think we are starting to find that SACCARES is emerging as an effective and accessible support for the parents that we serve that are from low resource and diverse communities. And in line with CMHA recommendations, if you can think back to that brief time earlier when I read that little description, I think this program does strive to foster a healthy and resilient mood, to create a supportive environment, and to allow parents to develop their personal skills. And finally, I do think this program also, to some extent, lends support for low-resource initiatives employing task-shifting approaches in mental health service provision. And these may come across as bold claims for a relatively young and green program, but I truly believe that these are the sort of bold approaches that we need to take in order to solve that central problem of access. And I mean, we hope to keep adapting and refining as we go, and adapting this approach to other populations in need if possible. And of course, continuing to study its effectiveness in the spirit of the scientist practitioner. I'd like to thank today our research partners, Dr. Jonathan Weiss and Ann Mills at York University, as well as the program team at SAC. So Dr. Shivajan Sivapalan, Nisham Shanmugalingam, our coordinator, who is right there, Geetha Murthy, our fearless leader, Kingston Ugandran, and of course our lovely, lovely volunteers without whom we would not have this program. Thank you. Feel free to ask me questions as our introduction person. There we go.
Thanks so much for your talk and for the great work that you guys are doing. It's a really important program.
Thank you.
I'm wondering if, and this is something that we at Autism Ontario are asking ourselves as well, what in your mind, and even from this experience, are some of those critical components of what makes that outcome of parents feeling less stressed, feeling less anxious, and so you identified those things as measures of those tools.
Mm-hmm.
But what's harder is trying to figure out what is that pivotal thing or things.
Right.
What are those key pieces? And we can guess and hypothesize, but it's hard to find good evidence on this in the literature.
Right.
And thinking about what's the sweet spot on helping families to have that type of outcome, or is it truly a combination of all of those things together
Right.
that create an environment that lands people in feeling not alone, and so those kinds of things are very difficult to measure.
Right.
So yeah, I'm really maybe making a comment more than a question that you may or may not have an answer to. And I think sometimes we know it in our hearts, but not so much on the evidence slide of
Yeah.
where do we find those key things to say every program that results in these outcomes for families contains these elements, or not. And maybe
Right.
it is really specific to a cultural context, a environmental context, access to good supports, whatever. Anyway, I'll stop talking and listen to what your thoughts are.
Yeah, no, I think that's a fantastic question, and it also presents more questions than answers, right? And with the structure of this, one thing that I'm hoping to do as we move forward with the research piece is really try to sort of isolate those elements, because there's so many different things that are coming together to create this confluence of factors that then has that output. So first of all, just the idea of like the peer facilitation. There's that element, there's the group element, and I think that is one thing I can speak to because we sort of had to pivot with our program from an individual format to a group-based format, because what we were finding with the early stages where we were offering sort of individual supports with the same content was that parents were not coming in, they weren't signing up at all. And then when they did, they would kind of stop after a couple of sessions. And I think for this particular community where these sorts of experiences are their first brush with mental health services, it can be really intimidating to seek services in that very individualized format. I mean, it provides more time for direct counseling perhaps, but I think ultimately that group-based format can be a really valuable way to get parents in the door, so to speak. And that also gives rise to an element that I may have alluded to with passion, which is that idea of common humanity, and really activating that piece for clients, the idea that they're not alone in this, and even though parenting, even with typically developing children, can be a very isolating experience, I think it's really powerful and validating to have someone sitting next to you who's gone through it, or even kind of in that spectrum of experience to new parents that I talked about. I think that can be really reinforcing. And then obviously there's also the content, right? So we're kind of talking through the different things that the CMHA recommended that we do, and I think we address those things really well, but I'm also curious to see what are the elements that are really speaking to parents, and also what is actually making a measurable difference. So yeah, it could be any number of things, but I'm excited to find out.